Good afternoon, everybody. Welcome to this afternoon session of the Day 2 PG Orientation Program, which is being conducted. And we have the first session on the cataract, and that is going to be chaired by Dr. Padmaja Krishnan, Madam. She is a retired professor of ophthalmology. She is a good orator, and she's excellent in English. So you can hear her talk during this course. Plus, she's been winning the debate consecutively for the last 2 years also. And this session will be moderated by Dr. Thomas George. Over to you, Dr. Thomas. You can unmute and take over the session.
Thank you, Dr. Rajiv. We'll launch straight into the session. The first talk will be by Dr. Arup Chakrabarti. Who else to tell us about biometry than the most renowned international cataract surgeon that we have in Ksos, Dr. Arup. He needs no introduction per se. Dr. Arup, can you please share your screen and start the talk?
Okay, friends, a very good afternoon to you all. I am sure all the inspirational lectures about how grand our subject is, ophthalmology is, and how it is expanding, everything has been dealt with in the day one and by the previous speakers. So it makes my job that much easier. I'm Arup Chakrabarti, and I have no financial interest in whatever I'm going to talk to you about in the next next 15 minutes or so. You know, as a cataract surgeon, we have witnessed that the patient expectations have changed over the years. You know, so we promise them that we will perform a surgery with very minimal pain or painless surgery. The surgery will be complication-free, and the patient downtime will be minimal. Visual recovery will be instant, and patient will have excellent uncorrected vision at distance. And if the patient wants spectacle independence, we can use special lenses and to make them spectacle independent at different distances of functioning. And all this will come with very little personal effort from the patient, because the post-op rehabilitation is pretty rapid without a long list of contraindications or activities that are not allowed. And patients also want everything at a very minimal cost. And by and large, we have been successful in meeting these objectives of cataract surgery. But from time to time, we come across patients who are very unhappy after cataract surgery. See, for example, this particular gentleman was creating some noise outside my cabin, and I quickly saw the case sheet. I had operated on his right eye almost 10 years earlier, and it was a monofocal lens. It was a standard foldable lens. And for some reason, fortunately, he was seeing 6.6 and N6 without glasses. So he was having a multifocal vision for some reason. I'll come to it later. On the fellow eye, which I had just operated, that was a much more complex scenario. It was a very hard cataract. Pupil was small. I had to stretch the pupil, but surgery went off extremely well. As a surgeon, I was very, very happy with the outcome. And you see here, he was having 6.6 with minus 0.75, and with just plus 2 add, he was having N6. So what exactly went wrong? Now, if you see the second eye that was operated, because of the stretch pupilloplasty, the pupil is slightly larger, slightly irregular. And in the fellow eye, this patient, of course, had senile meiosis, and he was having pseudo-accommodation in the right eye, and to a much lesser extent in the left eye. And so this was the problem which the patient had, and he was not sure what was happening. And patient just also told me that, doctor, I have paid more. Of course, there's an interval of 10 years between the first surgery and the second surgery, and inflation has to be taken into account. Surgery took longer. Yes, it took longer because it was a very hard cataract, and it was a small pupil situation. I had to use iris hook, more intraoperative manipulations. And patient, I also felt that there was inadequate interaction with the surgeon, with the patient, like the first eye. Like the patient was so happy, he invited me to play cards with him in Trivandrum Club, which of course I didn't do, and I had rejected his request. So there was a certain communication issue. So he was quite unhappy, even though everything had gone up pretty well. So friends, what I would like to tell you that unlike the days of yore, like when I was a postgraduate student like you, first year, cataract surgery was rehabilitative cataract surgery. If patient has a cataract, you have to remove the cataract. That's it. But today, cataract surgery has become a refractive cataract surgery, which means you would like to hit the bullseye almost every cataract surgery that you perform, and holy grail would be 6/6. And the patients also expect to see, the normal vision at the intermediate distance as well as at the near distance. So the patient expectations has improved a great deal, and we also, to a large extent, able to help them. So how do we meet these goals? Of course, it goes without saying that a surgery has to be very safe. There's no point in having a complex complication and think about normal visual recovery. And there are certain things that have to be taken into account. Like, for example, if the patient has a perioperative astigmatism cylinder, that has to be taken into account with the special surgical techniques and intraocular lenses. And if a patient wants to see at all distances of vision without aid of glasses, of course, you need to resort to a multifocal lens or a trifocal lens. And there are a plethora of such lenses, a new technology that is coming up. And last but not the least is the increased refractive accuracy. Even if you perform a good surgery, take care of the astigmatism, use a premium intraocular lens, but if you have not calculated the intraocular lens power properly, it will come to a naught. You are not going to end up with a satisfied patient in spite of your best efforts. Now, I will not be talking about the hardware of the presentation, which means I'll not tell you how to do a keratometry. I would not tell you how to do a scan biometry or optical biometry, because these require hands-on. And I have done these talks, and they're all up in the YouTube, in the AIS, in my AIS website, editor proceeding site. So you can have a look at that, because for you to know how to do keratometry, how to do optical scan biometry, optical biometry, or other investigation, they require hands-on. You require the machine by your side. So it is not possible, in the short span of time that we have today, to tell you about the hardware. So my main focus is going to be the theoretical aspects, the software behind it. So over the years, the IL-PAR prediction has become very, very accurate. It's because, we have had newer instruments and devices coming into the market. The formulas that we use to calculate the intraocular lens power, they have evolved, and we have very good formulas available today. Unlike 53 years back, when the first theoretical formula was published in the literature. And we have realized that there is a thing called a constant optimization of intraocular lens. Every type of lens has got a particular number. So we need to find out what that number is. And as I mentioned earlier, there are newer and newer instruments are hitting the market. They have very advanced features. But we must remember that we are in a developing country, and it may not, most of the hospitals may not have the finances to access these state-of-the-art equipment. So we still have to depend upon the older generation machines, and they do extremely well. It is, of course, there in the published literature that, those certain features may be absent in the older generation machines, but still, if you handle them correctly, if you interpret the results correctly, you get very good results out of these. And before I go further, I would like you to be familiar with certain names. They are basically the gurus of intraocular lens power calculation, the current gurus. This is Warren Hill of Hill RBF Formula. He maintains a website, and you will be visiting his website throughout your career as a cataract surgeon. Ken J. Hoffer Q Formula. Jack Holliday has done extensive work in IL-PAR calculations and in a lot of other field of activities in cataract surgery. The late Wolfgang Heigis from Germany, Thomas Olsen, Graham Barrett from Australia, the Barrett Universal 2 or Barrett suite of formulas, and the new kid in the block, Adi Abulafia, who is from Israel. So these are the people who have done extensive pioneering work in this particular field in terms of optimizing biometry or the formulas or how to get the best results out. And the literature is full of articles authored or co-authored by them. So they are the people you must be aware of who they are and what their contribution has been. Now, this is Sir Harold Ridley. He implanted the first intraocular lens 29 November 1949, and the results were not good at all. the first two patients, one had a overcorrection up to minus 21 diopters, and the second patient has minus 15 diopters. All right, so this is a result which is totally unacceptable today. So the surgeon and the IOL manufacturing company realized that there has to be some modification of the intraocular lens design, and that was done. And the next audit cycle with 25 patients did better. They had a minus 2.25 diopter of spherical equivalent, but still the range was from minus 10.5 diopter to plus 4.5 diopter. So this was the early results, in the early 1950s, late 1949 and early 1950s. But how are we doing today? So this is the data that is available in the Warren Hill website. So only 1% of the cataract surgeons, only 1% who use this particular website are able to land 92% of the patients within a 0.5 diopter of the target refraction. Only 6% of this of the cataract surgeons are able to get the same level of accuracy for 84% of the patients, and for the vast majority of the surgeons, plus minus 0.5 diopter accuracy around the target refraction is seen about 78% of the patients, which is not a very good number. Which means that these patients definitely, 22% of the patients will definitely require higher power glasses. And if I've promised the patients a life without glasses or reduced spectacle independence, they're not going to be happy patients. So we definitely have to do a lot to improve the scenario. And one thing a postgraduate student keeps in his mind is, the IOL power calculation is just a one-off event in the lifespan of the patient, in the lifetime of the patient. But what I would like to emphasize today is the IOL power calculation actually it transcends the entire perioperative period. There are important events happening preoperatively, intraoperatively, as well as in the postoperative period, which definitely plays a very important role in getting a good outcome for your cataract patients. So preoperatively, before you perform the scan, keratometry of the scan, you must examine the patient very thoroughly. You must have a look at the ocular surface. Last couple of years, we have realized that if a patient has an abnormal ocular surface, that has to be worked up and that has to be optimized. Patient counseling is very important, because there are some patients who will be happy with no reading glasses. They want planar for reading, which means you have to overcorrect them. So there are a lot of other issues which you'll be learning during the next 3 years' time. Biometric measurements should be made with a minimum of 2 devices, and again you use at least 2 formulas to calculate the intraocular lens power. And ultimately, once you have gone through that whole exercise, you select the appropriate intraocular lens for the patient. And during surgery, of course, as I mentioned earlier, the surgery has to be precise. It should be complication-free. The lens should be kept within the capsular bag, and there has to be a 0.5 millimeter overlap of the rhexis margin on the optic side, on the anterior optic surface. So this is what intraoperatively and postoperatively is the moment of truth. That's the time when you get to know how you have done, how your exercise in terms of IOL power calculation, how you fared in this exercise. So you get to assess your patients, the refractive outcome and the anatomic outcome, and then you take if the refractive outcome is not good, you may have to look into the reasons why it has gone wrong, and what could be done as a prophylactic measure for the future. And for the patients, what has gone wrong, there are various options, ways to correct them, to get them to the desired refractive status. So that is something that we as a surgeon will have to look into. So again, there are you have to use the right set of formulas, and when you take the measurements, make sure that you avoid the measurement errors, and that is by using certain validation guidelines. And I have already introduced you to the concept of lens constants, that each type of lens has a particular number, which may or may not tally with what is written on the cover of the lens. It may be written 119, but actually in your hands, the number may be 119.2. So that is something I will not be going into great details today, but that is important for us to keep in mind if you want to have a satisfied patient at the end of the surgery. So as regards the formulas, there are 7 generations of formulas, plethora of formulas, and we have stopped classifying the formulas in terms of generation. And this is the system that we follow. And historical refraction-based formulas, again, has been given up because we have more sophisticated methods. Pure regression formulas, again, are not really used. So what is popular today are the Virgin's formulas, and you'll be repeatedly hearing about the Holiday 1 formula, SRKT formula, Alpha Q formula, Hygiene formula, and then a Barrett Universal 2 and Holiday 2. And then there are certain formulas which are based in artificial intelligence. Artificial intelligence is playing a lot of important in our day-to-day activities in ophthalmology as well as in including cataract surgery. So this is one aspect where artificial intelligence plays an important role, and that is the Hill RBF formula. And so now there are two, if we have to know only two formulas for IL part calculation, one would be a Barrett Universal 2 formula. So this is available free at the APSCRS website. It is actually a suite of formulas. It takes care of all your IL requirement, IL part requirement, all kind of situations and scenarios. And there are certain machines, higher end machines, optical biometers, which may have these formulas incorporated in their software. Likewise, the Hill RBF formula is also free. It is available at the ascrs.org website. And then this also is a very, very accurate formula. So today, whenever I do an IL part calculation, I use only these two formulas. And then I find most of the time these two formulas speak in the same language. They give me the same numbers. If the numbers are not the same, if the IL part is not the same, there's a gross difference, then I'll look into other formulas and few other issues which is beyond the scope of the discussion today. So as I mentioned earlier, I mean, when you make the measurements, you have to make sure that the data that are feeding into these formulas have to be accurate. So you need to know how to avoid the errors in getting these measurements, and that brings you to the validation guidelines. See, for example, when we do the central corneal power, manual keratometry is most of the time we'll be doing. Reflective keratometry, which could be manual or which is automated perioperative reflective keratometry. This should be high density. There's a lot of points on the corneal surface should be taken into account while getting the K reading. And today, of course, the central corneal power can also be obtained from the swept source OCT. This is an additional feature of these SS OCT devices. Axial measurements traditionally has been done with ultrasound biometry, A scan as well as B scan. A scan has fallen into disrepute because of a lot of nitrogen errors that happen. It is always examiner dependent, the way you conduct the examination, the way you handle the probe and all that. So most of the time we would not use an A scan biometry, but maybe yes, we'll not be using a compression ultrasonic biometry, but we'll be using an immersion ultrasonic biometry if you don't have access to an optical biometer. Otherwise, optical biometer is what you have to go in for. And regarding measurement errors, for example, so if you may take the measurements and you find out that you are falling, your corneal power, let's say corneal curvature is very flat or very steep, or the axial length that we measure in the length of the eye is very either very short or very on the extreme of ranges, and there is gross difference between both the eyes. And then this is just to give you certain important examples, and there is a whole list of validation guidelines which have to be gone through by the biometrist. And it is important that as a postgraduate student, even I also do end up doing a lot of biometry, because as a surgeon, as an ophthalmologist, you are directly responsible for the visual outcome. It is not the optometrist or the optician or the nursing personnel who may be doing these scans, but ultimately the responsibility has to be taken by the surgeon. So the lens constant is very, very important, and particularly when a new lens comes into the market. And so it is like in every type of lens, every type of design will have a particular number which has to be fed into the formula. Now, what is written on the box of the lens may not be the same in your hands, so it may vary. So we need to be able to know how to calculate, how to optimize the A constant for the lenses that we're using. But if we're using a standard technique of cataract surgery, we do a 2.2 millimeter temporal clear corneal surgery, 5 millimeter excision, single piece hydrophobic acrylic design. So since almost of the surgeons follow this technique, so there is not much of A constant variation, much of a variation in the A constant in the hands of surgeons who follow this technique and use standard techniques of optical biometry and standard techniques and the standard intraocular lenses which have international footprint. But problem starts when you have a new lens that is coming up in the market, when the lens constant optimization becomes very, very important. So friends, in summary, you must you should know how to take the measurements, and that comes hands-on. Use validated measurements. Make sure that the measurements are really the pure, that they give you good, proper, right information. Work with properly optimized lens constants, particularly for the newer lenses that are coming up in the market, and adapt to new technologies as they present. But you must remember that anything that is new is the best, or has to be adopted. No, there are certain new technologies which come up and then they disappear, they go away, they go into the oblivion. But you must be judicious in selecting a new technology which you feel it fills up the void and gives you better outcome, and strive to use all available resources to their best advantage for you to get the best post-operative outcome, visual outcome in your cataract surgery patients. Thank you very much for your patient hearing. And it was a pleasure, Rajiv, and congratulations to you, for organizing such a wonderful meeting. Thank you so much.
Sir.
Thank you, Arup. That was a fantastic overview of what can be done. That is good. Next is my own talk, so I'll share my screen.
Let me introduce Thomas George then. He's what he would like to be called a glaucomatologist. So he's an anterior segment surgeon, a very good surgeon at that, and a very good speaker. So we look forward to hearing from you.
Thank you, ma'am. I will be talking over the next few minutes on about the surgical microscope. And a surgical microscope, if you look at the optics, this is a very simplified version of it. You have a single objective lens, and from there, the light takes two different paths through a set of tubes. So the right and left tubes have the optical elements. There is a magnification system interposed next, and that can be a zoom optics or a telescope optics, that Galilean telescope optics that is there. Then it goes through a set of prisms and goes to eyepieces where this it's adjustable in terms of IPD and things like that. So this disparity between two ends of the lens is what gives you the stereopsis, and it allows for a good stereoscopic visualization so that we can operate with a depth perception. The working distance is decided by the objective lens, and for ophthalm, in general, we have a long working distance of around 15 to 20 centimeters. That's why all the instrument handles are around this length. So if it's any more than that, it will hit the microscope itself, which is not sterile. The illuminating system must be able to evenly illuminate all parts of the surgical field we are interested in, and that would help not have any shadows and help us in our surgery. The microscope should be stable on an articulated frame balanced on it, and one should be able to adapt to a wide range of procedures. That means we need a fairly wide range of magnification. When you go for a higher magnification, your field of view or the area you see is going to come down. As also the depth of field, that is your ability to perceive the depth and the things in focus anteroposteriorly is going to come down at higher magnification as opposed to a lower magnification. Obviously, you would see things smaller and your resolution comes down with the lower magnification. Your magnification can be a step or a zoom system. The parts of a microscope would be the optical system, illuminating system, and of course the mechanical support. Optical systems quality would decide the quality of viewing that you're going to get through the microscope. The illuminating system, typically we have a coaxial illumination that would give a good red glow and is useful for intraocular surgeries. Whenever you want to see anything inside the eye, you're peeping through a small window, you need a light source that is not casting shadows, you need coaxial illumination. Whereas on the surface, you are better off with an oblique illumination. And there's one more reason why we should tend to go for an oblique on the surface, because these light sources are quite strong, and you have a long surgery, you can actually burn the macula. So phototoxicity of the macula is known with microscope light. So whenever possible, switch out of coaxial whenever you're working outside of the globe. What I mean is when you're doing the conjunctive also, you're outside. Only once the intraocular do you need the coaxial. The mechanical support is the one I will actually be spending time on. It is most understated part of the microscope, and the footplate is probably the most understated in this itself. The footplate is not just a set of wheels with which you can move around the microscope. Footplate is probably the heaviest part of the microscope, and it has to be heavy enough to prevent the whole microscope tipping over with the swing arm fully extended. And this, by the way, is the only thing that should be locked fully during surgery. No other parts of the microscope should be locked, and one can have some friction resistance given by those turning knobs, the essentially screws that add friction to the movement, so that you have a certain amount of non-jerky movement, but it should never be locked. You're not there for exercise, you go to the gym for that. Most OT personnel would find it convenient to lock all joints and swing arm for their convenience. Please insist otherwise, because you need the movement while you're doing the surgery. The articulated arm typically has got two joints. There is one above the footplate and one more joints, and a pivot onto which the microscope itself, so that you can rotate the microscope finely. This allows you to move it around on the XY plane quite a bit. And the centerpiece that is there is a swing arm with a counterweight at the other end. And all of these have got friction locks, and these should not be locked for surgery. They should be relatively free for movement during surgery. One thing that most of us are unaware of is how to balance the microscope. You have a knob at the back end of the swing arm with a plus and minus on it, and this turn is turned to increase the leverage of the counterweight. There's a huge counterweight in here which is balancing this microscope's up and down movement like a seesaw. You do not want to drop the microscope onto the patient, so this has to be adjusted perfectly. So what you need to do is to gently push the microscope down or up. If it's accelerating, it is not balanced. You turn the knob either way and find out where it is balancing. The plus side adds to the counterweight, the minus side decreases the counterweight leverage, but it doesn't matter which side. You turn one way, it's getting worse, you turn the other way. That's all. And finally, the microscope should not be freely moving off, and when you push it in one way, it should stop after a small movement. It should not be accelerating in that direction, up or down. All of you have seen this picture pertaining to the mobile. It is also true of the microscope. Your head tilted forward puts a lot of strain on the neck, and that's not good. So most microscopes have got tiltable eyepieces. Adjust it so that you are practically looking straight while you're looking through the microscope, and not keep it like something like this where you have to bend down and look downwards. Your neck will eventually give up if you keep looking down for long durations like for surgery. If you're going and buying a microscope with a fixed eyepiece, there are two options. One is a 90-degree eyepiece and one is a 45-degree one. The 45 may look good, but 90 is what you should go for if you're bothered about your neck. Always center the XY motor. When you push the centering button, both the XY and the focus up down usually centers. Some the microscopes do not have this centering, so there is a marking here, two triangles facing apex towards the center of it. The marker should be right there in the middle of those when you start surgery, because once you started surgery, you need the full range of movement possible from the motors as you press the foot pedal. IPD and refraction have to be adjusted for. It's always best if you're wearing spectacles, wear spectacles with your distance correction in place and use the eyepieces at zero diopter rather than keep changing it and taking off your glasses. It's just like driving. If you learn to drive with shoes, it's much more convenient. But some people have learned to drive with barefoot, and it is a bit of a hassle. Anyway, if after that you check focus one eye at a time, and if it's different, check if the eyepieces are fully pushed in. One may be pulled out a little bit or unscrewed a little bit, so they may be at two different planes. That's the first thing to check. If that's not, there's something wrong with the optical elements in the eyepiece, get it serviced, but in the meantime, you can adjust the diopter knob and focus one eye at a time. But in between, look in the distance. It's very easy to accommodate while you're doing this. So in between, keep staring off at the wall and then look back and see if it's okay. Adjusting the IPD, it's best to do it with both eyes open. Widen the IPD till there are two circles seen. Slowly bring the eyepieces close together till you see one fully illuminated, complete circular field. There should be no shadows in that circle. And this is seen with both eyes open. Look away in the distance to make sure you're not accommodating. Check again. And microscope optics are for distance vision. And even though when things are near your eye, you tend to accommodate. And to resist that, you have to look away and look back into the microscope. I have seen people trying to do this by closing one eye at a time. But when you do that, when you're adjusting for IPD, you are actually doing a cover test on yourself. Your foreas will break. We may have intermittent divergence squints that are not cosmetically apparent, and all these would break, and it's not physiological. Once you start operating, things are different, and it's going to cause asthenopia or eye strain. It's difficult not to accommodate. So as you're doing this also, in between, take a peep in the distance once in a way to make sure that you are not accommodating and inducing a convergence. So to go through again, you would see initially two circles which are illuminated when it's too far apart. As you come closer, you start seeing the side of the tube on the middle, and then you have something like this. This is a shadowy area. Then you land up with the endpoint where it's a fully illuminated, complete circular field. And when it's too close together, you would see the side, the outer sides of the tube, and you need to go back that way. Microscope is just one of the many components that are involved in microsurgery. To be comfortable with microsurgery, you need to pay attention to a few more critical areas. One, you should be comfortable. Your back should be relaxed and straight. You should not position yourself with a bend in your back or overstretched, because once you start your surgery, you're not thinking about your back, you're concentrating on surgery. At the end of the surgery is when you're going to get all your spasms. You should be able to reach the foot pedals easily, and it shouldn't have to stretch. So if you're too tall, you push the foot pedal away from you. If your legs are not reaching it, you can even ask for a footstool to be under the foot pedals. Your neck should be comfortably positioned. I already told you should be looking straight ahead and not down or up. So when you're sitting at the head under a microscope, you're much closer to the head of the patient, and your microscope is practically straight down like this. But if you're operating on the temporal side, as we do for our temporal phaco, typically temporal now, you need to tilt the microscope so that your back is still straight. If I had this position here, my head would be somewhere here, which means I'll have to have a bend like this, and end of the surgery, I'll have difficulty getting up again from the chair because my back is in spasm. So you need to tilt the microscope when needed, and as and when required. All these adjustments need to be done. The foot pedal switches can be configured different. This is not a pre-configured thing. You can configure this switch to be the same as this switch and things like that. So always check your foot pedal before you start your surgery. You typically have a toggle switch like this for focus, one side going up, one side going down, but sometimes you configure it so that up is here and down is here. And this one has got a zoom and focus as toggle, and illumination switches are there on this. So you have to figure out what. Only switch that's going to be constant is your XY. It's a joystick-like thing. You position your foot pedal so that your knee doesn't hit the table and you're not stretching to reach the foot pedal before you start the surgery. After it, all changes are going to be irritating to you. To achieve all this, you need a chair that can be adjusted up, down, a table that can be adjusted up, down, and of course, a microscope that can be adjusted up, down. A combination of all these positioning can accommodate any surgeon of any height. And once the surgery starts, we concentrate on the surgery. And by the end of the surgery, otherwise, your old sports injury that was a strain in the back or some joint is going to act up as a spasm, and you may not be able to get up from the table. At least when you're older, that's going to happen. Why am I emphasizing this? Because your health in the future will affect your professional life, not just your life. It's easy to do one case crouch down as we do in PGs. When you're learning, you're doing one case in a day. But we are planning on a career where we are doing longer, complex cases, depending on a specialty. If you're a VR surgeon or an oculoplastic surgeon, sometimes surgeries take 3-4 hours. Or if you're a cataract surgeon, you're planning to do many cases. Again, you're going to take hours sitting there in that chair and operating. And all these would contribute to disc problems. I'm not talking about papillary, I'm talking about intervertebral disc here. And that can stop your surgeries altogether at a premature age than what you had planned for. So almost all movements in ophthalmic surgery are what you call pill rolling movements or finger grip. Basically, only your finger is moving. The fine muscles of the fingers are all that's involved in the actual surgical step. For this to be controlled, your wrist and everything above has to be rock steady, and that is going to contribute to your control in surgery. So find and use wrist supports wherever possible. You can use the patient's forehead, the zygoma. You rest your wrist there and move your fingers. And most headpieces of tables come with a wrist support ring, which the OT staff would conveniently hide away in a cupboard, especially if you're sitting at the head end and operating. This is handy. It would come in the way if you're operating on the temporal side, so we may have to remove it also for that. But if you're sitting at the head end, use the head, the wrist support that comes with all the OT tables. Whatever is handy, you try to put your wrist down so that you're steady from wrist up so that your fingers can move perfectly. Also, the axial muscles have to be relaxed for your wrists to be steady. You cannot allow them to tire and start tremoring, and your surgery is going to be difficult. So your starting posture is very important for the rest of the surgery. Thank you. That's all I plan to talk about. Where it stops.
Thomas, like you asked, shall I start now?
Dr. Padmina, please start. I was just wondering whether
I hope you can hear me. I'm keeping my video off while I speak. Thank you. Okay, so good afternoon, everyone. Thank you so much, KSOS and Rajiv, for giving me this opportunity to speak to the newly minted ophthalmologists, whom it's always a pleasure to talk to, as they start on this career path with a clean slate on which we hope they will be writing bright and beautiful things. My topic for today is counseling. And I wouldn't be surprised if a few of you at least wondered what I would be talking about, whether I would be counseling you about becoming good postgraduates or about coping skills as you go through your 3 rigorous years of training. But funnily enough, it's neither of this. In fact, what I'm talking about is not with you as the counseled, but as the counselor. And actually, it's about patient counseling. So what is counseling? Counseling is giving advice, which we hope is wise, good, solid, relevant advice. Of course, to give advice, you need a lot of knowledge. You need to know exactly what's happening. And this orientation is just to sensitize you to the things that you will be dealing with as you go on. So you need a lot of knowledge before you can adequately counsel, just as you need to know all of ophthalmology if you have to take a good history or to know what you should be looking for in an ocular examination. But why counsel? What is the purpose behind patient counseling? The reason is you make the patient aware of his problem. You then increase, if you tell him about his problem, you show him the possibilities, what the treatment is like, what the treatment ensues, what are the possible benefits, are there any risks, are there complications? And when patients are anxious, apprehensive, talking to them. So one of the things you will need for counseling, which you will pick up as you go along by observation, is communication skills. So you make the patient appreciate what he has, what is the problem, what do we think about it, what are we able to do for it, and what are the problems along the way that he might have to experience. I've gone, like Arup was saying, we are old, at least I'm older than Arup in the profession, I think, and things have changed dramatically. When I was a postgraduate in training, all we said was, you don't have vision because it's a cataract. And the patient said, so what can you do about it? And we would say, we'll operate. And then he would ask, but endengiലും പറ്റുമോ? Will there be problems from the surgery? And we would say, oh, you don't have to worry. We'll give you back your vision. Just leave it to us. This was the old paternalistic approach. But over a period of time, as we got better at our jobs, and as patients became more aware of what they could expect from us, things started going wrong, especially with the media stepping in, expectations running high. And at that time, some of us went to the other extreme, where we painted the worst case scenario. So we told them this could happen, that might happen, and you frightened them. And then he had to be willing to accept all this and undergo surgery. I believe that we have to balance both these. You have to project that you are confident, that you're capable, that you will give back vision, or whatever you're treating will cure him of or relieve his condition. But at the same time, you have to make them aware that though most of the time there are no problems, there are problems, there are issues. And I have, again, this is a technique I've developed over the years, which brings down the atmosphere, the tension in the room. So when they ask me, doctor, എന്തെങ്കിലും പറ്റുമോ? So I say, look, everything has complications. Think about it. You've come to me now, you're going home in a vehicle. Can you guarantee that you will get home? Leave alone that, I'm walking on this floor at the moment. Can I be guaranteed that I will not fall? But most cases you will get home and I will not fall. So there are complications. There are complications to everything. Nothing I can say is 100% foolproof or safe. But we are aware of this. We try to avoid these complications. And that being so, it should be possible for you to get back the vision. At the moment, I'm talking mainly for cataract, but honestly, it holds for glaucoma, where we have such a problem with patient compliance because they're not aware why they should be using their drops. With retinal surgery, with lasers, we are trying to maintain the vision they have. Very often, we're not able to improve it as much as they would have expected. So counseling should also moderate patient expectations. I have a patient who has a cataract, but who has a macular degeneration. So then I must make him aware that, or it may be cataract in an amblyopic eye, that you cannot expect the vision in that eye to become as good as the vision in the other eye. Finally, we are treated as the experts, as is often the final word in a patient who is a supplicant, who's come to us for help. And whatever we say often goes. So you have a lot of power. And I can give you examples which could have happened in real life too. Supposing I have a patient with a bad abdominal pain, which could be constipation, could be appendix. Now, if I want to do an appendicectomy, I could counsel him saying, look, this is probably just a constipation, but it could also be an appendicitis. And if it were, it might cause an abscess, it might rupture, you might get peritonitis, which is really, really serious. And then I say, but you decide whether you want the surgery or not. Or I can, to the same patient, say, look, this is probably only constipation. Let me give you an enema. And if that doesn't work, we will rethink, and probably you might need an appendicectomy. So this is me talking, whichever I say, the patient is being swayed by me. So what I'm asking all of you is to be ethical, to be empathetic, to put your heart and your mind together, to be on the side of the patient, and to counsel the way you would if it were for yourself or one of your families. Because often it happens that I see patients come to me who have been advised cataract surgery and who have been told that if they didn't do the surgery, it would become hypermature, that it would complicate. And sometimes, or rather more than once, I've had these patients improve with glasses, and they never tell me that they were posted for cataract surgery. So after I've prescribed the glass, the patient says, Timiranda. And I say, why do you ask that? Your vision is good. It's 6.6 N6 even. And they say, Allah, Timiranda. So then I say, look, തിമിരം എൻ്റെ കണ്ണിലും ഉണ്ട്. ഒരു പ്രായം കഴിഞ്ഞാൽ നമുക്ക് എല്ലാവർക്കും തിമിരമുണ്ട്. അതിപ്പോ തിമിരല്ലല്ലോ, നമ്മൾ അതിന്റെ കാഴ്ചക്കുറവാണ് ചികിത്സിക്കണേ. കണ്ണട വെച്ചിട്ട് കാഴ്ചയുണ്ടെങ്കിൽ why should you bother? And then he brings out his medicines and a paper saying that he was posted for cataract surgery 2 days hence. Very often, I have not known where to look or what to say. But now my standard answer is, look, this was not the doctor who told you that. This was the professional counselor who has been taught about the complications, but who has no idea of the level of your cataract. I'm sure that someday you will need cataract surgery. And probably the reason why they told you this was because if you got it done early, you would have that many years of clear vision. That is one situation. The other situation, which I find upsetting with cataract surgery counseling, is that we often advise the higher end lenses. This again, the counselors have been primed into pushing for the higher end lenses, the lenses that cost more. And of course, the higher end lenses, the more costly lenses, have their advantages. I will never run them down. But across from them is a patient who really cannot afford it, who having to buy this would cost him a lot on the home front. There, I feel it's not fair. And it sometimes cuts very badly, because I had a patient with financial reverses. He was a well-to-do man, and then he had financial reverses, and he was brought to me by a friend, a mutual friend, who asked, could I do anything for his cataract? Of course, I was not operating at all, but I referred him to a colleague who very kindly not only operated without cost, but actually put in a higher end premium lens, which had been given to her as a sample. The patient was fine. He had some diabetes. We worried about whether he would have more of inflammation. He did excellently post-op. The vision was 6.6, as it often is on day 1. But 6 months later, when he came for cataract surgery in the other eye, when he still couldn't honestly afford it, he insisted that he pay for it. And I asked him, why? Do you have problems with the other eye? And he said, ഇല്ല, അത് എന്തോ ശരിയല്ല. അന്ന് വെച്ച ലെൻസ് അത് ശരിയായിരുന്നില്ലല്ലോ. അത് ഫ്രീ ആയിട്ട് വെച്ചതല്ലേ. So this is the other thing. You put before them who can't afford the higher end lens, and then they say we can't afford that, and then they opt for the lower end lens. But in their mind, it's not a lower end lens, it's an inferior lens. So the lens that you first offered was the good lens. The lens that he was obliged to accept was the poor lens. And here again, patient satisfaction comes down. They always feel that they've been shortchanged. They feel sorry that they had to make do with less than not. So here again, I have an analogy. I say, look, if your aim is to get from Calicut to Bombay, you could go by bus, you could go by a sleeper class, you could go by air condition, you could fly. But ultimately, you'll get to Bombay. And getting to Bombay is getting back your vision. But along the way, if you took the flight, you'd be there in a couple of hours, absolutely fresh. If you took the bus, you might have a backache, you might have problems. So my answer is, isn't it true for everything? If I want to buy a sari, if I want to buy a shirt, don't I buy what suits my pocket? In the same way, none of us would put inferior lenses into the eye. All these lenses were meant to help you to see, but all of them, as the price goes up, the quality of the lens, like in a camera, the price of the camera is the price of the lens in the camera. You might see slightly better, but I can't say how you would see with the other lens. So if all you want is from not seeing to start seeing clearly and to read the board, let me assure you that all these lenses are equally good. So I will finish my talk with a few what I would call take-home messages, that when you counsel, remember that you are the expert and therefore whatever you say goes. Second, make sure that you inform your patient. Never ever try to sell a product. Inform what is available. Tell them that these are the better quality lenses when they can afford it. Tell them 100% the eye will look beautiful the day after. You will be able to drive and do what you want. So there are advantages. And those who can afford, by all means, they are the people who should be buying the higher end lenses. And lastly, in this and in everything else, be empathetic and treat your patients as you would like to be treated yourself. Thank you very much.
Excellent, ma'am. Straight from your heart. Touches a raw nerve for all of us. Thank you. Next, we have Dr. Sashikumar. He is our ex-president. For the last many years, he, along with Mohan sir, have been going around trying to teach us all what to do in an OT and what not. Dr. Shashi, please take over.
Thank you, Thomas. The topic which was given to me by Dr. Rajiv was OT etiquette. But now the question is about quality. Whatever you do, it should be of top quality to the patient. And the major share of quality of our services is contributed by the surgical outcome, and that is from the operation theater. So I thought it's better to rephrase my talk, like prime yourself for the sanctum sanctorum of your hospital, which is the operation theater. And you should learn the concept of zoning in an operation theater. That means we have got 4 zones in any operation theater, starting from the outer zone, that is a protective zone, the clean zone, the disposal zone, and the aseptic zone. These are nothing but different zones of varying microbiological count, so that it reduces the unproductive movement of the staff, the materials, and the supplies, and the patient. And thereby, we will be able to reduce the extent of hospital-acquired infections. I must confess that this is not from textbook. This is purely from my experience. What you ought to learn from the operation theater. I've broadly classified it into 3 heads. One is to pick up the right attitude, to know the routine work in the OT, and how to improve your skills to become a good surgeon. And the attitude comes punctuality, know your team. You have to take care of the patients. There are certain do's and don'ts in the theater, and you have to be very careful about your language. So all these things you'll have to master in the first week of your OT session itself. And the next is the routine works that go on in the theater, the hand hygiene, the OT dress, the checklist, various checklists that we have used in the theater, what are the sterilization methods in the theater, and how the waste is managed in the theater. And finally, to improve your skills, you have to know the procedure, you have to start assisting surgeries, then you have got wet and dry lab training these days, and finally, you will muster sufficient skill and courage to start doing the surgery. We'll take it up one by one. See, punctuality is very important for a doctor. I would say for a doctor, they should be punctual. And you have to develop that habit. See, for habit, people say that the word habit, you remove the H, a bit remains. You remove the A, bit remains. You remove the B, still it remains. So you develop that habit so that by the time you become a good senior consultant, you will have that punctuality in you. And if the scheduled time for surgery is 8 o'clock, the postgraduate should reach the ward at least half an hour before to ascertain the latest status of the patient, and you can brief the consultant about that. That would definitely pick up an impression of you in the consultants. They will realize that you're there to you mean business. You're not come as a spectator. You have to pick up the right attitude. For that, the team that you are working with. That is not only the surgeon, the assistants, the staff nurses, the technicians, even the housekeeping staff. All of them form the team. So you should develop the habit to greet them when you come, to communicate well with them, and to acknowledge their services when and where possible. Next is how to care for the patient. Everybody cares for the patient, but there are certain small things which you may think is negligible. But see, nowadays we give a shoe cover or foot cover for the patient. That is a plastic thing, and the patient will be walking on mostly very slippery floor, very shiny floor, and there is a chance of slipping while wearing this plastic thing on a smooth floor. Just place your foot in front of the patient, in front of the feet of the patient when the patient comes down from the OT table, or just gets up from the wheelchair. This will avoid slippage. It's not a great thing, but still this means that you are caring and you have got concern for the patient. And about the language, see, the most of the surgeries that we do are under local anesthesia. So the patient is fully conscious, and since they don't have any vision, the other senses are tuned to receive the impulses. So they will hear everything. All communications between the staff and the surgeon and the assistants, all communication should be professional. And maintain your calm and composure in adverse events. Don't scream. Don't just say, oh, ah, ouch, ayo. All those things that will convey a very bad impression. The patient will get frightened. And another thing is that once you start doing surgeries, don't be temperament. If you get shout at your assistants or just show temper tantrums, this mood is highly contagious. You will spoil the entire mood of the operation theater. So that will reduce your performance. There are certain do's and don'ts in the theater. You should never come fasting. Usually people come skipping the breakfast. That should never be done. Your stomach should be full, but your bowel and bladder should be empty. Avoid unnecessary movements in the theater, especially in the sterile zone. And when you are standing for something, especially when you are assisting a surgery, you should shift your weight from one leg to the other to reduce a chance of postural syncope. And never show haste in the theater, especially in the recovery room and all those things. If you are running through the recovery room, patient will get frightened. So do not show haste in the OT. This is the sterile zone I mentioned. See, the head end of the table, that is the most sterile zone. So you should never cross this space between the trolley, or don't try to watch the surgery standing here. You can stand here and you can watch the surgery in the monitor. And don't bring any mobile, books or newspaper, etc. in the operation room. And do not bring eatables in the OT. And do not touch sterile surfaces with unsterile hand. Do not lean onto surface, because all these surfaces are considered unsterile, even though you have disinfected that surface, but that is considered unsterile for a person who was draped for surgery. Do not open the hand with gloved hands, because even after surgery, if you are opening it with the gloved hand, you are going to contaminate that surface, so that the next person is at danger. Do not keep multiple doors open while the surgery is in progress. Here also, do not drop articles on the. Sometimes after some few weeks, you will be asked to take a sterile thing, transfer a sterile thing onto the trolley. So do not drop it on the trolley like this. Instead, the scrub nurse should take it outside the border of the trolley like this, with the gloved hand or with a artery forceps. Like this, when you are transferring fluid, saline or betadine or whatever, it should be transferred outside the trolley. And this is one which is very common in the theater, but it should never be used in the theater. It is not at all advised. And if it is unavoidable, you should always autoclave it and store it dry and not put it in a Dettol or Savlon solution. Next is hand hygiene. Hand hygiene, the routine unscientific hand wash will leave so many areas untouched. So we'll come to that the next step. And this is a nail brush. It's called a nail brush, and it should never be used in any other part of the forearm or hand. It should be used only to clean the nails. This is the accepted standards for surgical hand wash. There are 6 steps which you should follow, which is described in the European norms. The OT attire, when you are entering the theater, all staff, all the doctors, assistants, the housekeeping, everybody should change out to the OT dress completely. Remove all jewelry, and your arm should be bare below the elbows. Avoid free-flowing robes. It should be comfortably fitting. You have to clip the nail short. Avoid bindi, kumkum, sandal paste, etc. on the forehead. And never put OT clothes over street clothes. And you should not develop the habit of pinching the nose over the mask. You should change to normal clothes before going to toilet, and wear the cap and mask properly. This is the talk of the town nowadays with the corona. And the mask should cover the entire aspect. The sides, the top, and the bottom should be covered well when you are wearing the mask. And you should learn the proper way of donning and doffing the surgical gown, and the types of gloving, and how to the posture attained after properly donned. This is the open. There are 3 types of gloving methods. One is the open gloving. Here also, you never touch the outside of the gloves with the bare fingers, so that you once you hold the folded part of the glove, and then after putting on the fingers, the other hand also is other glove also is applied without holding the outer surface. Here is a closed gloving where the fingers are within the edges of the cuff. Here also you will not touch the outer surface of the gloves. This is an assisted gloving where you can slide the hands into the glove, which is kept open by an assistant. After properly putting on the gloves and the surgical gown, you should never fold your hands like this or fold it down like this. You should hold it in the namaste posture, sufficiently away from the mouth. That is the correct posture that should be attained. There are several checklists that are maintained in the theater. You have to study the checklist, and you have to start running the checklist at various stages. Most important is to verify the patient, the eye, and the surgery that is to be done. Then you have to learn the steps of surgery and record surgical notes meticulously. This is the routine checklist that we use it in our hospital for the nursing personnel, checked by the nursing personnel. And this is the pre-operative checklist that we use. And this is the surgical safety checklist that we use. There are a lot of checklists which you should be aware of. Then in the OT routine, this is a very important topic, the sterilization. You should know the basics of sterilization, how your instruments are getting sterilized. The most common is the steam sterilization, which is used for heat resistant articles. And for heat sensitive articles, we use the ethylene oxide and the plasma sterilization. Then we should know whether once the cycle is complete, we should know whether the items are sterilized or not. For that, there are several indicators, the chemical indicators, the biological indicators, and then the air sampling and the culture of the air. Then you should know how surfaces are getting disinfected at the end of the surgical session or at the end of the week. These are just a list of chemical indicators that are available. There are about 6 indicators available. Right now, they are coming out with a 7th indicator, chemical indicator. And this class 1 indicator is very commonly seen. It comes as a roll and it is affixed on all the packs, but just mentions whether it is the pack is processed or unprocessed. This is a class 2 indicator, which is used, is otherwise called a Bovidic test pack, which is used to assess the amount of vacuum that is created in the sterilizer, the autoclave. This is the class 6 indicator, which is otherwise called emulators. This is the best available now. This has got a stated value, and if the autoclave attains this value, this color, the yellow color, will turn to blue. Then you will know that your items are sterile. But the best is the biological indicator, where a large number of resistant bacterial spores kept in this container are processed along with the autoclave load. At the end of the process, we'll send it for culture. But if it grows organisms, then your cycle is not proper. But it takes time. Then next is about the waste disposal. There are different color-coded containers. This is for infectious clinical waste, the yellow one. The red one is for infected clinical waste. And you should know how these items are segregated at source. And there are other the puncture-proof containers for sharps. This is for sharp metal, and this is for sharp glass. And finally, you have to improve your skills, know the procedure fully. Then you start assisting your consultants. But for assisting, you should know the next step. You have to anticipate the next step. For that, you know the surgical steps well. The hand should never cross the surgical field, and the instrument should be handed over in an ergonomic manner. Replace the instruments. Suppose you give a forceps to the consultant, he gives it back, and it should be replaced in the correct place. Because if he asks for it again, otherwise you will be groping around if you don't locate it properly. And most important, if you feel dizzy, inform and leave the operating field. Otherwise, you will produce an embarrassing situation, dangerous situation. How to learn surgical steps? There are a lot of options available. You have dry labs, the wet labs. There are several gadgets available like this, which are useful for dry lab settings where no tissue is used. In a wet lab setting, you can use the goat's eye or the pig's eye or even cadaver eye to learn the important surgical steps. And as Dr. Thomas mentioned, you have to maintain the correct posture right from the beginning. Better to use a microscope with a tiltable optics. And always learn to do surgery through the microscope, never under the microscope. Because the usual tendency is that you just switch on the illumination and then start doing surgery beneath the microscope. That should never be done. And as I said before, never show panic. Even if you create a PC rupture, or if you have a dropped IOL or a dropped nucleus, don't show panic. You call your consultant. He will come and manage it. Don't shout there. Don't scream there, because the patient will get frightened. And never ever hesitate to stop your surgery if you find difficulty. Then you call your senior. He can come and do the surgery and do good for the patient. And finally, the one important thing is that you should not be a spectator in the OT. You should not just see, you just observe things, just like Sherlock Holmes. And this is just one small example of how observing things will make it better. This is the suturing technique, just a demo of two gauze pieces. Once you pass the suture, the initial position is prone position of the hands. Once you pass the suture through both the edge of the wound, the hand comes in the supine position. But then after that, you have to re-grasp the needle, and that should be grasped not in the supine position, it should be grasped in the prone position, because otherwise you'll find it difficult to take the needle out of the wound. So this can be picked up early by a keen observer. If you just watch the surgery without observing, you will not be able to pick up all these small points. And to conclude, there are slow learners and fast learners in surgery. Never get disappointed. Don't say that my colleague, he has picked up surgery fast and he is doing it fast. Don't get discouraged at this, because there are people who are very slow, but they will pick up later. And always be positive, and more important, be proactive in the operation theater. And you have to start now during your training period. Enjoy your life as an ophthalmic surgeon. Thank you.
Thank you, sir. That is a very good presentation. Overall, the session was excellent. I thank Arup sir, Thomas, and Shashi sir, Padmaja madam for that wonderful session. Now we'll move on to the next session. It is going to be on retina. It will be chaired by Dr. Papa madam and moderated by Dr. Gopal. Dr. Gopal, take over. Madam, you can take over.
Very good afternoon to all. Let us start the session on retina. We have reached the last lap of this PG orientation marathon. So in this session, we have included certain investigations that we routinely do to diagnose retinal diseases. The first talk will be by Dr. Manoj from Chaitanya Eye Hospitals. He'll be speaking on optical coherence tomography. Over to you, Dr. Manoj.
Thank you, ma'am. Are my slides visible, ma'am?
It's visible.
Okay. Thank you, ma'am. I'll be introducing you to this topic, optical coherence tomography. So OCT, or optical coherence tomography, represents a non-invasive method for cross-sectional imaging of the retinal structure. So, and it is based on the principle of low coherence interferometry. So basically what happens is from the light source, the light from these machines is split into two beams. One beam goes to the eye and the other beam goes to a scanning or reference mirror. And the reflected light from the reference mirror and from the eye is kind of integrated, and the interference between these two waves that is obtained is interpreted, and that's how we understand the reflectivity of the tissue that we are studying. So this is basically the principle of interference. So this is how we perform the OCT. It's basically a non-invasive test. It's within minutes you get a wonderful cross section of the retina, as you can see here, which is very close to what you see in histology. So that's a great thing about this non-invasive test. Now, because it uses light, whenever there are media opacities, the media opacities are going to obstruct the light entry, and therefore you cannot see the underlying tissues. So here, as you can see in the top slide, you see there is some kind of a lesion sitting on top of the retina, which is not allowing the light to pass through. So you don't see anything underneath it. In this lesion here, you see there is a choroidal lesion, which is not allowing the light to pass through. So basically, you should not have media opacities, or when you have opacities, it means something, or it rules out certain lesions. Like in this example here, you see the retinal layers are absent here, the outer retinal layers are absent, and because of which light passes in easily, and therefore the choroid gets highlighted. So this, you have to keep these principles in mind before you start looking at OCT images. In this image, you see there are different types of hemorrhages. You have pre-retinal hemorrhages, you have intraretinal hemorrhages, and subretinal hemorrhages, and all these are causing changes in reflectivity, and therefore the underlying tissue is visualized in different forms. So basically, you need to understand that there are three kinds of machines. You have the time domain machines, the spectral domain machine, and swept OCT machines. The time domain machines are the earlier generation machines. The resolution of these machines are poor. The study of vitreoretinal interface is very poor in these machines. Study of the outer retina or the photoreceptors also is poor in this machine. So that has to be kept in mind. The spectral domain machines have good resolution, and that is what we commonly use. We also have the Ksos OCT machine, which has the highest resolution. And this is the machine that one needs to use if you have to study choroidal pathology in detail. We also use different scanning protocols. When you look at the printout, you would see these scanning protocols that are employed. Different machines use different scanning protocols. There's something called a line scan protocol. There is something called a radial scan protocol, and this is called raster, where there is a series of lines which are used to study the pathology. Now, this is the international nomenclature. So when you see the OCT, these are the different layers that you see. This is very similar to what you see on histology. You see the nerve fiber layer, you see the ganglion cell layer next, And then you have the inner plexiform layer, then the inner nuclear layer, then the outer plexiform layer, and then the outer nuclear layer. As you can see, the outer nuclear layer and the inner nuclear layers are less reflective. The plexiform layers are more reflective. And then you have the outer retina, which consists of the external limiting membrane. And then the next reflective layer used to be called the ISOS layer, and now it is called the ellipsoid zone. And then underneath that, you have the interdigitation zone. And below that, you have the retinal pigment epithelium and the Brooks complex. The next thing that you need to know is that we define lesions on the OCT as either hyperreflective or hyporeflective. Now, this is an example. See, this is more white in color. This is called hyperreflective. These are all examples of hyperreflective lesions, where when you see something which is more white on the OCT image, then it is hyperreflective. When it appears darker, then you call it hyporeflective. For example, the outer nuclear layer is hyporeflective. The inside of a PED, a serous PED, is hyporeflective. Then when you study the choroid, we talk about block transmission. So when you have something which is obstructing the light on the top, you don't see structures underneath it. This is called block transmission. And when there is no layers on top but allows light to pass easily, when the choroid gets very prominently seen, then you call it as hypertransmission. So these are the terms that we generally use when you describe OCT. So this is the checklist that I usually tell my fellows. This is the checklist that one needs to have. Whenever you get an OCT, just identify what is the type of scan that this machine is involved. Is it a time domain scan? Is it a spectral domain OCT, or is it a Ksos OCT? How is the scan quality? Is it just a retinal scan, or is it a choroidal focused scan? Now, there are certain scans which focus on the choroid. These are called enhanced depth imaging scans. And then you look at the contour of the scan. I mean, the image that you get, is there a generalized change in the contour, or is there any focal areas where the contour has changed, like a foveal contour? Is it affected? And then you have to start looking at a particular order. You start from the vitreous, you look at the surface of the retina, you look at the superficial retinal layers, then you look at the outer retinal layers, and then the choroidal layers. So, and each of these layers, you need to look for alterations in reflectivity. You comment on whether the lesion that you see is hyperreflective or hyporeflective. And then finally, you decide whether this scan is enough, or do you need more scans to study a particular disease. Some diseases you require multiple scans to study that disease in its entirety. And then you also can make measurements. So this is the checklist that one needs to have before you start looking at OCT images. Now let us see a few examples. Now these are images of time domain OCT. So this is the first generation OCT images, which, as you can see, has very poor resolution. You don't see the individual layers very clearly. In contrast, if you look at these images, these are spectral domain OCT images, where you can see all the individual layers very clearly. You can see the outer layers, especially the photoreceptor layer and the retinal pigment epithelium, and all that is very clearly seen in the spectral domain OCT. Now, this is an example of a Ksos OCT, where in addition you see the choroid very clearly. So looking at the scan, you can identify you need to identify first what is the type of scan that you are dealing with. The second thing is looking at the contour. Now look at this. This is how a normal retinal image would look like. But look at this here. The contour, the generalized contour of the image itself is altered. So then you understand that this is a patient with myopia. In myopic eyes, the contour may be altered. Then you look at any focal change in contour. Here you see the contour is changed in the macular region alone. In all these entities, it may be just presence of fluid, or it may be some lesion of the retinal pigment epithelium which is altering the contour, or it could even be a choroidal lesion which is altering the contour. So that also you can look at it at one glance. So then you start going layer by layer. You look at the vitreous. Here you see a thin membrane reflectivity. This is called the vitreomacular adhesion. In vitreomacular adhesion, the foveal contour is not altered. So that's the most important thing. In contrast, when you see membranes like this, which has altered the contour of the fovea, then we call it as vitreomacular traction. So these are the two terms, vitreomacular adhesion, vitreomacular traction. And based on the size, they are further classified into focal and broad. You look at the surface of the retina. In the absence of such vitreoretinal interface changes, the other vitreoretinal interface changes could be epiretinal membrane. See the surface of the retina, this is how it should be. Here there is a break in the surface. Here there is a thickening on the surface, this epiretinal membrane. Here if you see carefully, there are some small folds that you see on the surface. They are nothing but internal limiting membrane folds which may be secondary to epiretinal membrane. Then you look for partial defects like these. These are examples of partial defects, partial retinal thickness defects. This is here you can see the associated pathology. Here there's a vitreomacular traction causing the partial lamellar hole, and this is epiretinal membrane with a pseudo hole. Sometimes now you can also see defects within the retinal substance without any traction outside. So these are called as lamellar defects. These are typically seen in patients like macular telangiectasia, where you can see these small defects in the inner layers or in the outer layers. This is a condition called microhole, where there is a focal area of loss at the photoreceptor layer. So these are also lamellar defects. And finally, you have full thickness defects, where you can also see the associated pathology. Here you can see there is a vitreomacular traction causing the full thickness defect. Here there is a full thickness defect with an epiretinal membrane. And this situation, you can also see subretinal fluid along with the macular hole. So all this can be made out on the OCT. The next thing is you look at the middle layers or the inner layers of the retina, and look at the reflectivity within these layers. Normally you see these lines of reflectivity. As I said before, you have hypo and hyper reflective lines that are seen. But when the inner retina is totally replaced by increased reflectivity like this, then you know that you are probably dealing with a vascular entity, and the inner retinal vascular entity. It could be arterial occlusion, or it could even be a venous occlusion here, in which case often you have a lot of fluid underneath that. Also, sometimes you can get focal areas of reflectivity here, like this. This also is a vascular pathology, which is now called as PAM, paracentral middle layer maculopathy, which is again a vascular event. So then you look at hyporeflective areas. So these are examples of hyporeflective areas. You see this, these are generally called cysts. Cystic, they contain fluid. Some of the cysts may have some content. These are called turbid cysts. And the cysts may be present, they're usually present in the plexiform layers. But sometimes you may see it in different layers, in both the plexiform layers, as you can see in multiple layers, as you can see in this picture here. And when you see fluid under the retina, that is in the subretinal area, between the retinal pigment epithelium and the neurosensory retina, then this is called as subretinal fluid or submacular detachment. Now, this is commonly seen in vascular pathologies and can also be seen in post-surgical situations. Now, one common example is central serous retinopathy. So here, these are examples of patients with central serous retinopathy where you have this subretinal fluid, but along with that, you see certain signs, like you see this is elongation of the photoreceptors that may be seen. You may see fibrin deposits within the subretinal fluid. This is a vacuole sign that is described along with the fibrin deposits. You see this vacuole-like appearance. So these are signs that help you to make a diagnosis of central serous chorioretinopathy. Sometimes inside the subretinal fluid, you may see septa-like things. Now, when you see such things, then you know that it's an inflammatory pathology, like VKH. So this is a patient VKH having this finding. And sometimes the subretinal fluid may have blood inside it. So then you have to think of entities like choroidal neovascularization. Sometimes you see these cysts, which are extensive like this. Now, these are patients with juvenile X-linked retinoschisis. So sciatic retinas also can appear like this. So this is a differential diagnosis for cysts. Many of these conditions are bilateral. These are examples of macular schisis in myopic eyes. You can see these sciatic cavities. Often you see the septa that are very evident in these eyes. Next, we look at hyperreflective areas. Now, some of these hyperreflective dots may be very small like this. Some of them may be very large or thick like this. Now, these small things are called hyperreflective spots or dots, whereas the large ones represent the hard exudates or what we call as intraretinal hard exudates. But these hyperreflective spots are also seen not only in vascular pathologies, it can also be seen in age-related macular degeneration, as you can see in these OCTs here. So when you look at the outer retina, always when you talk about outer retina, we put all these layers together. We look at the external limiting membrane, we look at the ISOS layer, which is now called as the ellipsoid layer. We look at the interdigitation zone, and then we look at the RP and Brooks complex. So all of these together, we call this as outer retina. Now there are certain diseases where the outer retina seems to be affected. Now these are examples of drusen's. Now where you see the pathology is lying under the retinal pigment epithelium. The retinal pigment epithelium is pushed, and therefore the overlying layers are also pushed. And this is a confluent drusen. So these are drusens are usually like this, but when they get together, they become confluent drusens. Now these are examples of retinal pseudodrusens, where this enlarged picture clearly shows that the deposits are lying between the retinal pigment epithelium and the ellipsoid zone. So this is retinal pseudodrusens, or even called as subretinal drusenoid deposits. Sometimes you have these elevations of the retinal pigment epithelium with fluid collection. So these are serous pigment epithelial detachment. They are commonly seen in CSR, but it can also be seen in age-related macular degeneration. Sometimes this area has some content, as you can see here. There is some internal reflectivity within the PEDs. Then this is called as fibrovascular PEDs, or what we normally call as type 1 choroidal neovascularization. Some of these PEDs may have zero sanguinous content. So there may be some portion having some reflectivity, some portion not having reflectivity. And sometimes it may contain blood, as you can see here, which does not allow light to pass through. So this is a hemorrhagic pigment epithelial detachment. Sometimes these pigment epithelial detachments can have reflectivity within it. So when you see layers like this, they are called multi-layered pigment epithelial detachments. And when you see this kind of laminated bodies, they are called multi-laminated pigment epithelial detachment. Now, OCT is very helpful in differentiating choroidal neovascularization. Now, this is an example of a classic CNVM. In classic CNVM, the lesion is above the retinal pigment epithelium. So this is the retinal pigment epithelium, which is fairly looking normal, except for a small breach here, but the lesion is lying above the retinal pigment epithelium. This is also called as type 2 choroidal neovascularization. So in contrast, in type 1 choroidal neovascularization, the lesion is lying under the retinal pigment epithelium. This is the retinal pigment epithelium. You see the reflectivity is lying under the retinal pigment epithelium. So this is also called as occult choroidal neovascularization, or type 1 choroidal neovascularization. Now this is another example of a patient where you see the retinal pigment epithelium is throughout elevated. All the content is lying under the retinal pigment epithelium. So this is a diffuse type 1 CNVM. Whereas in this patient, you see there is a retinal pigment epithelium and you have the contents under, but at this point, there is a migration of these hyperreflectivity going on top of the retinal pigment epithelium. So this is a mixed CNVM where there is a type 1 CNVM and also a type 2 CNVM, or both classic and occult CNVM. So OCT helps us to understand the exact location of the choroidal neovascularization. So this is a typical OCT of a patient with RAP, retinal angiomatous proliferance. So because this is primarily a retinal disease, you see this reflectivity in the retina, and then you also see an element of pigment epithelial detachment. So this is a typical OCT finding of a patient with retinal angiomatous proliferance. This is a scarred CNVM. So in the CNVM scars, you see there is just an area of reflectivity there. So based on the presence of fluid, we classify CNVMs into active and inactive. Now this is a CNVM which has a lot of fluid. Yeah, subretinal fluid, has intraretinal fluid. We call this an active CNVM. So in this patient here, there is no fluid. We would call it as an inactive CNVM. Similarly, for macular edemas, again, when we're looking at the location of the fluid, we classify patients as having centrally involved macular edema. Here, where the fluid is exactly at the fovea, then we would call it as centrally involving macular edema. When the fluid is not involving the fovea, we do not call it centrally involving macular edema, because this is the patient who require anti-VEGF therapy. Now, sometimes the outer retina, especially the photoreceptor or the ellipsoid zone, may be absent in as patchy like this. You see the layer is absent here, patchy, or there may be a diffuse loss of layer with just preservation of the central area. So this is a typical finding that you see in hereditary dystrophies, like in retinitis pigmentosa, and also some of the drug toxicity, like in chloroquine toxicities. So where you may see the preserved central island of photoreceptors. Beyond that, you don't see the ellipsoid zone. This is an example of a patient with IJT who had a diffuse or patchy areas of ellipsoid zone loss. So this is a patient with geographic atrophy, where now you see the retinal pigment epithelium is totally affected there, is lost there, and therefore light easily passes through, and therefore the choroid is visualized. So this is an example of geographic atrophy. OCT is also helpful to study the choroid. If you see, so this is what I said as enhanced depth imaging. So with a normal OCT, sometimes the choroid is not very clear. So you need to use this mode, which is called the enhanced depth imaging mode, which is available in most of the machines. This helps us to study the choroid in detail. But however, as I said before, the Ksos OCT is the best OCT to study the choroid. So here you can see the larger vessels. These vessels are the hallux vessels, the smaller vessels are the satellus, and these small dots that you see, they represent the choriocapillaries. Now this is very useful because when you see a patient with CNVM, if you look at the thickness of the choroid, it helps us to identify what is the type of CNVM. Now these are examples of CNVMs where you can see the retinal pigment epithelium primarily affected, but you see the choroid is thicker. So if you have a thicker choroid with a CNVM, then this is most likely to be polypoidal choroidal vasculopathy, PCV. Whereas this is again another patient with CNVM, but here the choroid is not thickened. So this is how a typical AMD looks like. So typical AMD is the choroid is not so thick. In PCVs, the choroid is thicker. And this is a myopic CNVM where the choroid is extremely thin. So if you have a CNVM with an extremely thin choroid, then it helps you to make a diagnosis of myopic CNVM. Now in this patient here, you see the whole choroid, the architecture is lost. You don't see any layers. You don't see the hallux, satellus, choriocapillaries. The whole architecture. Also, you see a lot of folds. Now, this is seen in UAT conditions. Now, this is the patient VKH who has this pattern. And now this is another lesion where you see there is a solid lesion because it's blocking the light going through, and you can see it's almost got a very smooth contour. So this is an example of a patient with the choroidal melanoma. In choroidal hemangioma, if you take an OCT, what happens is you see a lot of blood vessels still preserved amongst the tumor. So that helps us to differentiate between choroidal melanomas from hemangiomas. This is a patient with.
Excuse, Dr. Manoj.
Yeah?
Time. I think you have to.
Just a minute. So these are examples of patients with lymphoma where you see irregularity of the choroidal contour, and this is where sometimes you may confuse with the choroidal mass, but sometimes the contour is abnormal because of certain inherent defects. Like this is a dome-shaped maculopathy that you see in myopia. So I think finally I will also mention about it's possible to even measure the thickness in patients. On the OCT, you can measure the thickness. There are nomograms that are available that also helps us in follow-up of these patients. You can use a caliper, or they have inherent modes by which the thickness is evident. And finally, nowadays we have OCT angiography, which helps us to study the retinal layers. There are different layers of blood vessels that we have identified: the superficial capillary plexus, the intermediate capillary plexus, and the deep capillary plexus. And this is very helpful in studying disease like diabetic retinopathy, where the foveal avascular zone is very obviously affected, and in identifying CNVMs. So to conclude, OCT is very much part of retinal imaging. And with all this multimodal imaging that has come in now, it is very useful to identify a lot of macular as well as retinal pathologies. Helps us to differentiate a lot of choroidal pathologies and helps in making a very clear diagnosis. Thank you.
Thank you, Dr. Manoj, for that excellent talk. Next speaker is none other than Dr. Gopalas Pillai. He's the main pillar of all the Ksos scientific programs, and he will be speaking on B-scan of the posterior segment. Over to you, Dr. Gopal.
Thank you very much. Am I audible?
Yes.
Yeah. Is my screen also visible? Is my screen also visible?
Visible.
Yeah. So thank you for this whole educational program. Dr. Rajiv sir has done a wonderful program, and we are reaching the fag end of that with retina. So I'll be talking about ultrasonography. It is a rapid, non-invasive imaging method and evaluation of anatomy of the eye, and media clarity or haziness do not affect it. So it is a two-dimensional brightness display where the strength of the returning echo is basically displayed as a dot on the screen, and those dots are joined together to form the ultrasonography. So these are the properties of sound waves. It has a wavelength, it has a frequency, amplitude, and velocity. And what we are doing is the production of ultrasound is by piezoelectric crystals. and that sound waves are being sent inside the ocular tissue, and then the echo which is generated from those tissues are brought out, and the images are amplified. So just telling, these are piezoelectric crystals, and high frequency sound waves are transmitted from a probe into the eye. Sound waves strike the intraocular surface, and each surface has a different reflectance, and those reflectance are converted into electrical signals and amplified. So where is an ultrasound indicated? Whenever there is difficult direct visualization of intraocular structures. We all know that, unlike all the other structures in the human body, eye is completely transparent. Most parts of the eye are visible through a very transparent cornea, anterior chamber, lens, and vitreous. So majority of the optic nerve, the retina, all those are seen very clearly. Only very peripheral places like the ciliary body area is a little difficult to see. So if there are significant lid edema and torsal tarsorrhaphy, you cannot open it up. Corneal opacity like scars or severe edema, you are not able to see it. Hyphema, hypopyon, or pupillary fibrin, or vitritis, which is dense, or any of those things, dense cataract through which you cannot see the posterior segment, or vitreous opacities, you will do an ultrasound. The frequency of the ultrasound that we use for abdomen is about 2 megahertz. For posterior segment is about 10 megahertz. And for ultrasound biomicroscopy, use for 50 to 100 megahertz. Higher the frequency, lesser is the penetration, and greater will be the resolution. That is how the frequency of an ocular ultrasound is somewhere around 800 microns, whereas that of a UBM is about 50 microns. Amplification of the display can be done by adjusting the gain. Low gain means increased resolution. The resolution power is much higher. High gain means there will be a lot of grains, but it will pick up even smaller problems. So there is increased sensitivity. And that is how we do an ultrasonography. There are different probe positions like transverse, longitudinal, axial, and there is a mark on the upper part of the probe, and where that mark is there, we will see it on the ultrasound as the uppermost part. That's a very important thing whenever you want to actually make a position of the ultrasound. Now, a normal ultrasound is looking like this. I will just show you some of the normal lens. Is seen as an oval high reflective structure with intralesional echoes. Okay, so now this is a lens. The second picture here shows the lens. This is the posterior capsule. This is almost a clear lens. Whereas as the lenticular, intrasubstance, the echo increases, that means there is more of a cataract. And sometimes there can be reverberations behind it when you have a pseudophakia. Vitreous is usually acoustically clear, but can show low reflective echoes depending upon the amount of syneresis. Like, for example, these are some PVD, something like this. These are normal in older people, or in myopes also post 35 years, 40 years, you can see a lot of PVDs like this, and thickness can completely be different. And retina, choroid, and sclera are seen as a single high reflective structure unless there is a problem in it. And optic nerve is a wedge-shaped acoustic void in the retrobulbar region. So you can see this is the optic nerve here, and you can see the cupping which is on the surface. Here is again an optic nerve, and the retina and the choroid, all those things are composite here. Now let us go into clinical uses of each of these areas. Vitreous, we can pick up vitreous hemorrhages, vitreous inflammation, other intravitreal echoes. Sometimes you may have to repeat the scans to see how things are changing. Now in vitreous hemorrhage, you can have without PVD, with PVD, subhyaloid hemorrhage, areas of attachment. These are very important. It is not just to pick up a vitreous hemorrhage. If you see the red blood cells in the retrolental area, or even during an indirect ophthalmoscopy, you are able to see blood. Your diagnosis of vitreous hemorrhage is done. But we do an ultrasound basically when we are going inside for a surgery, where to start inducing the PVD, where PVD is already there, where there is a tight adhesion. All these things have to be made out when you are going in for a surgery for a vitreous hemorrhage, and that is why an ultrasound is very important. Now, this initial picture is there. There are a lot of point-like echoes which are moderate to high in intensity, but you can see that there is no PVD. Whereas here you can see there is a clear space between the posterior hyaloid, and you can see that is a complete PVD. And within the PVD, we have vitreous echoes, mild to moderate echoes, point-like echoes. So that is with PVD and without PVD. Now, there could be partial PVD as well, like many of these cases in which like diabetic vitreous hemorrhage, PVD is more difficult to come. Whereas the vascular block with neovascularizations with PVD, or age-related macular degeneration, which can bleed, and subretinal hemorrhage breakthrough into the vitreous, all those can have PVD. Now you can see sometimes there can be partial PVD. You can see the attachment here, and it is attached to the disc. So this could be partial PVDs. And retrohyaloid hemorrhage is another important finding. So whenever there is a retrohyaloid hemorrhage, we understand that the vitreous is significantly lifted up from the retina. And so there is a space through which you can maneuver that posterior hyaloid, and the prognosis in such patients are extremely good. And so these are retrohyaloid hemorrhages, and you can find out the actual area of attachment. And then sometimes subretinal hemorrhage can come. This is an old person with vitreous hemorrhage here, but you can see that there is a subretinal hemorrhage also. The retina itself has lifted, and the density of the subretinal hemorrhage is usually much higher. So now there are some membranes in the vitreous. Dr. Papa, you can tell me when it is time. When about 2 minutes, you can please tell me. Membrane in the vitreous, which is PVD, RD, and choroidal detachment. So this is a normal PVD, as I told you. This is almost a total PVD. The important feature here is to do a dynamic ultrasonography. You are keeping the probe in one particular location, defining the PVD, and ask the patient to move here and there, and we will actually see the movement of the PVD. The movement of the PVD will be undulating and very slow movement in a PVD, whereas it will be rigid and flapping in the case of a retinal detachment. So this is a retinal detachment. So the difference between a PVD here and a retinal detachment here is that the retinal detachment is always attached to the disc when you are looking at the disc. If you are not looking at the disc, it can be sometimes completely separated. So you have to always look at the disc and see whether the thick membrane, which is very hyperechoic, is attached to the disc. Whereas a PVD is having much lesser echo texture, and even at high gains you will be able to see. At low gains it may disappear. A retinal detachment will never go away in a low gain. Even if you reduce the gain to significantly lower levels, the retinal detachment will be there. Then I talked about dynamic, the movement, and the ultrasound. This is a very typical signature echography of a choroidal detachment. This is like two sides are joining together. If it is more, then it is called a kissing choroidal. Now, vitreous haze. Now, I want to tell you that the amount of vitreous hemorrhage and the amount of echoes may not always go hand in hand. It is very important in case of vitreous haze as well, in uveitis or endophthalmitis. Just because you did not get an echo on the ultrasound doesn't mean there is endophthalmitis. Or just because you got some echoes in the vitreous doesn't mean that there is endophthalmitis. It's both ways. It is very it's important to understand that, because normal PVD can also lead to echoes, and sometimes significant endophthalmitis may not lead to echoes, basically because the tightness of the structure, the vitreal structure, actually gives rise to the medium-shaped echoes. So this is like a endophthalmitis. In which, so usually in a endophthalmitis or vitreous haze, it will be similar to a vitreous hemorrhage. It's extremely difficult to differentiate between a vitreous haze on the one hand and vitreous hemorrhage on the other hand. Vitreous hemorrhage will have will have red blood cells retrolentally, and vitreous haze will have white blood cells behind the lens. Now, vitreous haze, it's important to do serial scans to look at evolution of PED and evolution of VR pathology. Sometimes you can have dislocated lens into the vitreous. You can see this is a lens which is dislocated into the vitreous. Any other material can also, so sometimes there can be a dislocated lens, like this is a lens which is dislocated. You can see that the posterior capsule is moved a little back, and this could be either some other foreign body, or it could be probably a lens matter. If it is a metallic foreign body, you would usually see a shadowing here. This is not a metallic foreign body, is what I would understand. In retinal detachment, I told you something about retinal detachment. So retina is always attached to a disc and will have very high echo density. There are some exceptions, like a giant retinal tear, which is completely loose, and a large tear, which is completely detached. Sometimes you may not be able to actually find out the disc, and there will be multiple layers of the membranes there. So this is in a very low gain, and even in very low gain, the retinal detachment is seen. Sometimes it can be very high and thick, like in a PVR, this is a PVR. So posterior PVR is there. Probably this we would see as an open funnel, and this we would see as a closed funnel. You can see that this opening up of this particular thing is closed here. So this is a closed funnel. Sometimes there could be retinal detachment along with vitreous hemorrhage, either that there is a tear occurred on the surface of the retina while the tear was coming, or there could be a traumatic retinal detachment with vitreous hemorrhage, etc. Tractional retinal detachment always has some element of traction, and there could be combined secondary rhegmatogenous retinal detachment or pure tractional retinal detachment. You can see that there will be multiple vitreous echoes which is pulling, and the pulling has to be made clear, and the mobility of these retinal detachments won't be there like a rhegmatogenous retinal detachment. A rhegmatogenous retinal detachment is mobile, like a flapping. PVD is significantly mobile and very slowly mobile, whereas a traction retinal detachment wouldn't move. But the area of traction and the pull on the retina and the deformity of the surface of the retina will be seen. An exudative retinal detachment will show up as, there will be shifting fluid. So if you move here or there, the fluid may shift from one side to the other, and there will be a causative factor for the exudative retinal detachment, like a tumor. You can pick up a tumor, you can pick up a, any other things like that. In a VKH with exudative retinal detachment, the thickness of the choroid will be significantly high, etc. So here you can see a tumor, or here also you can see a tumor with exudative retinal detachment. Okay, again, this is a retinal detachment with closed funnel. RD can take myriad forms. This is a cyst within a retinal detachment. You can see that this is not taken through the optic nerve. So any area of the eye can be imaged and a myriad form can be produced because of that. Okay, so these are all, you can see here, the retina is slightly elevated, a shallow retinal detachment is there. Here it is a GRT which is crumpled down in one particular area. So RD, some of these retinal detachments you can see clinically, and then you are just doing an ultrasound for an academic interest. But yes, you should do that so that in a white cataractous eye, you will be able to actually make out the different morphological features of the retinal detachment. Here is a retina which is right behind the lens. This will be very difficult when you're going inside. You will always go into the subretinal space and cause problems. And this is an intraretinal cyst in a retinal detachment. Choroidal detachment, suprachoroidal bleed, suprachoroidal abscess, choroidal thickness, all these are very important. Like as I told you, this is a signature ultrasonography, a morphological marker of a choroidal detachment, wherein there are two from either side, there will be a compressive lesion like this. And these are massive kissing suprachoroidals. There is blood underneath the kissing choroidals also. Okay, so these are all different types of kissing choroidals. Now, choroidal thickening is seen in a lot of conditions, including endophthalmitis, including posterior uveitis or pan-uveitis, including posterior scleritis. But in posterior scleritis, it's very marked. It is called a T sign. Okay. Now, scleral rupture is a very important. Scleral or corneal rupture occurs, and you will not be able to, clinically examine because the view will be very hazy. So you should do a very soft ultrasound to make sure that there is no posterior scleral rupture, which is a very bad prognosis. Sometimes you can pick up staphyloma and color. So this is a posterior staphyloma. Can you see the U-shaped cavity here? That's a posterior staphyloma. This is a coloboma, and this is a scleral rupture. This is a posterior scleral rupture following a trauma. You can see that the prognosis is very poor whenever there is a posterior scleral rupture because you will not be able to approximate those. Uveitis, as I told you, vitreous haze is an important thing. Disc edema, exudative retinal detachment, etc. So here is a disc edema. You can see the disc here, the optic nerve is here, the disc is here, disc is edematous. Okay. Now vitreous haze, as I said, there will be a lot of point-like echoes in the vitreous cavity, and definitely this is a cysticercus. There's a cyst with a scolex in the center. This is a cysticercus. And tumors, yes, it's very important. Detection of opaque media, as well as differentiation of tumors between tumors in a clear media, and also to understand the tumor size, the height, the base area, and whether the tumor is progressing or regressing with our treatment. So melanoma, metastatic cancer, hemangioma, retinoblastoma are some of the tumors. Malignant melanoma usually will have lower, intralesional reflectivity. There will be some acoustic hollowing, And so that will be seen in malignant melanoma, and it's usually a collar stud shaped lesion. Metastasis will have medium to high internal reflectivity, and it will be usually solitary, not multiple. And choroidal hemangioma will have high internal reflectivity. Choroidal hemangioma will be definitely having more reddish hue, whereas melanoma in most cases will have that pigmentary hue. Okay, retinoblastoma will definitely show calcification. So the other tumors may not show calcification. Retinoblastoma will definitely show calcification, and the age group is also different. Okay, sometimes you can pick up orbital tumors. If the frequency that we use is slightly lowered, you can penetrate into the orbit very clearly and see orbital tumors which are compressing the optic nerve. And tuberculoma, choroidal abscess, all these things can be made out. This is a case of osteoma. Osteoma is a very thick bone-like tumor in which you will look like you are seeing a double optic nerve. Like this is the normal optic nerve, and this is the osteoma with the subretinal fluid. And you can see here also there is an orbital shadowing because of the calcium within the osteoma. Optic nerve cupping, disc edema, disc drusen. So this is optic disc edema, which we showed. This is drusen of the optic nerve, which will also show up in our autofluorescence. This is a glaucomatous cupping. A very mild cupping can be seen here. And ultrasound can also help in color Doppler. You can see the blood flow through the ophthalmic artery. You can see the blood flow through the central retinal artery. And also you can see tumor circulation. So 3D ultrasound is also to do the tumor sizes. Thank you very much.
Thank you, Dr. Gopal, for the nice talk. Next, I will be dealing with the fundus fluorescein angiography. Is it visible?
Yes, madam.
Yes, okay. So this is the fundus camera used to do the FFA. And this is the dye used. It is sodium fluorescein dye. And it's bound to 80% bound to plasma proteins. The thing is that it leaks through the choriocapillaries. So to assess the choroidal vasculature, FFA is not of much use. But the retinal pigment epithelium and the capillary endothelium act as barriers. So we'll get a good view of the retinal circulation with this fluorescein dye. These are the different concentrations available, and we commonly use the 25% of 3 ml. And this is the principle. When the light passes through the blue excitation filter in the camera, it will reach the patient's retina and it excites the fluorescent molecules on the retinal vessels. And they emit a light of different wavelength, that is a green light. And this green light passes through the camera's barrier filter and is captured by the camera. Like in any other invasive procedure, you should get a consent. You have to plan which eye to be imaged. You have to dilate the pupil. There is no test dose for FFA. First you take the color photo, then you change the filter, take the red-free photo, then you adjust the filter and do the fluorescein angiography. You inject the dye and start the timer. And this is the position of the patient and the technician. And you capture every second for about 30 seconds to 1 minute of one eye. Then you go to take the photo of the fellow eye, and you have to take the 3-minute photo, which is the recirculation phase, and ask the patient to look in different directions, and you can take the peripheral photos also. And the late phase photo is at 8 minutes. And let us see the normal phases of FFA. The time of dye to reach the retina is around 10 to 12 seconds. And the first phase is known as the pre-arterial or the choroidal phase, which lasts for 1 to 2 seconds. Then the arterial phase, where the retinal arteries are filled up, lasts for 2 seconds. Then comes the capillary phase. Then the venous phase, again divided into the early laminar flow and the late phase. Then the recirculation phase at 3 minutes and the late phase at 8 to 10 minutes. This is the red-free photo where both the arteries and veins are appear as darker. These are the different phases, and the pre-arterial phase, what you can see is both the retinal artery and vein both are appearing as dark lines and both are not filled, but you get a hyperfluorescence of the choroid. If the patient has got a celioretinal artery, that may be filling in this choroidal phase. This is the arterial phase where you can see the retinal arteries are filled, but the veins are appearing as darker. And this is the early venous phase or the laminar flow, where you can see the veins are filled up, but in a laminar flow. The central part of the vein is clear. This is the late venous phase where the veins are also filled up and it is as bright as the arteries, and most of the changes of perifoveal capillary network and leakage you get in this phase of the angiogram. This is the recirculation phase, which you usually the dye is of less concentration, and you can see that the dye starts to fade away from the retinal vessels. The late phase, they usually at 8 to 10 minutes, where only the this will show the hyperfluorescence. And if you are seeing some hyperfluorescence at this phase, that is abnormal. These are some of the common indications, and with the advent of OCT and OCTA, most of the indications of FFA has come very less. But in case of dyslesions, you can do. In case of diabetic retinopathy, there are certain indications, and you can find out the leak in CSR, retinal vein occlusions, vasculitis, and these are some of the conditions we commonly do fundus fluorescein angiography. The contraindications are if the patient has got history of any severe allergy or previous history of allergy to fluorescein, in pregnant ladies, in the cases with the renal disease when the creatinine is very high, it is better to avoid the test. In patients with coronary artery disease and bronchial asthma also better to avoid the test. The side effects, the common side effects are nausea and vomiting. That depends on the fastness of injection and the concentration of the dye we use. Skin rashes can occur. You have to tell the patient that there will be yellowish discoloration of urine and skin for next 1 day. And severe anaphylactic shock and even death can occur with FFA. Now, when will you say fundus fluorescein angiogram is abnormal? Then when there is a hyperfluorescence or hypofluorescence, or then when there is an autofluorescence or pseudofluorescence. And what is this hyperfluorescence? When will you get? When there is a RP change or RP atrophy, there you may see the choroidal fluorescence through that damaged RP. That is called the window defect. And there can be leaking defects. Normally, the retinal vessels will not leak, but in case of microangiopathy, capillaries may leak, microaneurysms can leak, new vessels can leak. Then pooling defects you can get in RP disruptions, and staining you can get in retinal scars. Hypofluorescence is usually due to any blocking defect by the blood or pigments, and filling defects because of capillary non-perfusion, or there is an occluded vessel is there. And this is pseudofluorescence. Normally this should be completely dark, but here in this case you are getting the light, that is because of the old filters which is allowing the blue light to enter the camera. So we have to change the filters. This is autofluorescence that you see in optic disc drusen. That is before injecting the dye itself you are getting the fluorescence. So this is usually seen in optic disc drusens. This hyperfluorescence, you can see there is a motile hyperfluorescence temporal to the macula, but as the FFA progresses, you can see it is fading. That is because of the window defect corresponding to the area of retinal pigment epithelial atrophy. In this case also, it's an AMD. There is areas of RP atrophy, and this hyperfluorescence decreases as the FFA progresses. This is a patient with the PED where you can see there is a hyperfluorescence and the intensity increases, but the size remains the same as the FFA progresses. That is indicative of PED. And this is a leakage where the hyperfluorescence increases in size as well as intensity as the FFA progresses, and that is indicative of leakage from a choroidal neovascular membrane. This is also a choroidal neovascular membrane. And this is a case of occult CNVM. You get a lot of hyperfluorescence in the late stage because of leakage. Staining, a scar on the retina can also produce a hyperfluorescence in the late phase because of staining. And in diabetes, we can see the hyperfluorescent dots, the microaneurysms which leak the lipids. And the new vessels also we can see that appears as hyperfluorescence, which increases in size and intensity. In this patient, you can see leakage from the disc also. That is because of the neovascularization of disc. A patient diagnosed as a severe PDR, but severe NPDR, but fluorescent angiography shows the leakage. So it is a case of PDR. Other changes that you get in diabetic patients is you can get capillary non-perfusion areas, intraretinal microvascular anomalies. You can see so many changes in the small vessels of the retina, and you can get venous dilatation, venous beading. And how will you differentiate a collateral from a new vessel? Collaterals usually will not leak fluorescein, but a new vessel will leak fluorescein. In a diabetic patient's presence with a macular ischemia, there will be an unexplained visual loss. And when you do the fluorescein angiography, normally there is a foveal avascular zone, but in these patients, you get a widening of the foveal avascular zone. You can see that hypofluorescent area involving the fovea. And cystoid macular edema usually produces a petalloid pattern of hyperfluorescence in the late phase. And this is seen in diabetic patients as well as in post-op patients. Areas of capillary non-perfusion usually appears as hypofluorescent areas. And in case of retinal vein occlusions, you can see the occluded vein is not getting filled up. In the first picture, you can see the supratemporal vein is okay, but the infratemporal is appearing as a dark band. It is not yet to be filled. And you can see areas of capillary non-perfusion also, staining from the vessels in the late phase, and leakage also sometimes you can see. Block fluorescence is a feature of retinal vein occlusion where the retinal hemorrhage is blocking the circulation. As in this picture, you can see the retinal hemorrhage is blocking the circulation. In case of macular BRVO, you get block fluorescence and late leakage. This is one type of block fluorescence that occur in a patient with subretinal bleed. The retinal circulation is not blocked, but the choroidal circulation is blocked in this condition. This is a case with a supratemporal BRVO where you get the dilated occluded vein and the hypofluorescence due to capillary non-perfusion. And this patient has developed a neovascularization, so you can see the leak from that area also. This is a case of cilioretinal artery sparing in CRAO where you can see the occluded artery, but the perfused part of the retina is supplied by the cilioretinal artery. And in case of vasculitis like Eales disease, you get venous sheathing and staining of the vein and leakage along with this hyperfluorescence. That is a feature of inflammatory vasculitis. This is a case of CSR where you get a leakage. The shape can be a ink blot or a smokestack. It is because of leakage which causes pooling of the dye. In a patient with asteroid hyalosis, it will be difficult to see the fundus with the ophthalmoscope or the fundus camera. So when you do the FFA, you can see all the details. This is a degenerative condition of the retina called Stargardt's disease, and you can appreciate the dark background because of the silent choroid. This is a feature of this condition. And when a patient presents with unexplained visual loss, if FFA helps in diagnosis, as in this case, it's a case of cone dystrophy, where you can see the typical bullseye maculopathy lesion. And these are streaks emanating from the optic disc. They are actually breaks in the Bruch's membrane seen in angioid streaks. These are all window defects, and it's usually associated with choroidal neovascular membrane. In case of inflammatory choroidal lesions also, you get initial hyperfluorescence and later hyperfluorescence. So initially hypofluorescent areas, later they become hyperfluorescence in inflammatory choroidal lesions. And in leakage also you get pinpoint hyperfluorescence initially and later pooling of the dye causes extensive areas of hyperfluorescence. That is because of the leakage. It is difficult to differentiate papillitis from papilledema in these patients because both this shows leakage, but in pseudopapilledema there is no leakage. In case of anterior ischemic optic neuropathy, you may get filling defects in the optic disc involving the choroid also. So nowadays the ultra-wide field FFAs are available. With the normal fluorescent angiography, you are seeing only the 30 degrees. So if you say take the 7 standard films, you are seeing only this much area of retina. But when you use the ultra wide field FFA, you can get 180 to 200 degree view of the retina. So it is very useful in different conditions. Like in PDR, you can do a targeted PRP, and peripheral ischemia is the most important cause for a recalcitrant macular edema. So we can diagnose that, and most of the changes in posterior uveitis, vasculitis, and vascular occlusions we can diagnose with this ultra wide field FFA. And this is one picture which shows that there is a lot of capillary non-perfusion inferiorly as well as temporally. And this picture also you can see the lot of capillary non-perfusion or non-perfused retina mostly in the peripheral part. Different machines are available. Heidelberg and Optos are the most common ones. And this is a peripheral neovascular NVE in sickle cell disease, and it is usually diagnosed best with an ultra wide field FFA. This is CRVO with extensive peripheral ischemia. So the amount of peripheral ischemia you can clearly diagnose with an ultra wide field FFA. And the effectiveness of PRP also we can assess. In this patient, the PRP has been done, but you can see a lot of peripheral areas has been left, and you can see the active NVD as well as NVE. So this patient needs more laser. Thank you for your patient listening.
Excellent talk, Papa. Excellent. It was a
Okay.
very wonderful 15 minutes. I think all postgraduates should hear it again and again.
Thank you.
Now over to Manjit for his talk on Amsler's grade.
Am I visible and audible? Am I audible?
Yes,
Can you
Manjit.
speak a little louder? Little louder.
Okay. So my talk is on Amsler grid. This Amsler grid was devised by Professor Mark Amsler in 1945. He was a Swiss ophthalmologist. So what we test in Amsler field is only a part of the visual field, that is around 20 degree of the visual field. This classic picture is the trackware hill of vision surrounded by the sea of blindness. In Amsler, with this technique, we are testing only the tip of the hill. So the principle, as you can see here, this is the Amsler chart which we have. We have these charts with multiple square pattern. You can see that it has around 400 squares, that is 20 into 20 squares. The total sheet is a 10 centimeter square sheet, and we have 400 squares in it. So the total one side will subtend an angle of 20 degree when the sheet is held at a length of 14 inches. Each square will subtend an angle of 1 degree, and if you consider from the central visual axis, you can see that all around we have 10 degree covered in this Amsler chart test. So altogether you test around central 20 degree of visual field, 10 degree from the center of fixation all around. There are two types of charts mainly, testing charts and recording charts. Testing charts itself are of 7 types. Most of them have a black background with white or red lines. We'll come to it. And the recording charts are in the reverse form. They have a white background with black lines. So these are the 7 types of testing charts. You can see that except for the 6th one, every other chart is having a black background with either white lines or red lines. So chart 1, this is a commonly used one. It has 400 squares, a central fixation spot, black background, and white squares. Second one is used for people having poor central fixation. When they cannot fix the central spot, when there is a central scotoma, you use 2 diagonal lines and ask the patient to look at the probable site of intersection of these two lines. The third one, here you have red lines in black backgrounds. So this is especially useful to detect color saturation or in optic nerve lesions, where the loss of red lines may be better appreciated. The fourth chart, instead of lines, they have random dots in black background, and it's used to differentiate a metamorphosia from scotoma. The fifth and sixth one, they are especially used in patients who complain of metamorphosia while reading. So here you have only horizontal lines, and in the sixth one, where you have a black background with white background with black lines, and you can see that towards the center the lines are more closely arranged. The seventh one, in addition to the first grid, in the central you have a densely packed line grid, and each smaller grid will certain an angle of half degree. So what we commonly use is only the first grid. So this is the recording chart. This itself can be used as the recording as well as the testing chart, and this is the most commonly available type of Amsler grid chart. So how will you do the test? You need a good lighted room. Patient should be asked to wear the reading specs and hold the chart at the reading distance, and each eye should be tested separately. The patient is asked to look at the center dot. If we cannot see the center dot, you should draw two diagonal lines and ask to look at the center of the intersection. Then ask him if he can see all four sides. Ask if there are any lines or squares are missing. That means there is a negative scotoma. Ask if they see any dark area on the chart, which indicates a positive scotoma, and look for any distorted lines. That means that the patient is having a metamorphosia. And you ask the patient to draw the abnormality by himself. He may draw an area of dark area in the field of vision or distorted lines. So what's the clinical significance? Generally, it helps to differentiate between a macular disease and optic nerve disease. Macular diseases usually show dark areas or distorted lines. So in the first one, this is a typical appearance in a case of central serous retinopathy. You can see a dark central scotoma. Second one, this is a case of macropsia. Like when a patient is having a ERM, contracted ERM with pucker, the photoreceptors may be close together. So more number of photoreceptors will be stimulated in a particular area, and patient will have a macropsia. This is a pincushion effect or a micropsia, where like in macular edema, the photoreceptors may be displaced more farther apart. So lesser number of photoreceptors will be stimulated, and this will result in micropsia. So this macropsia and macropsia are both examples of metamorphopsia. And in optic nerve lesions, you may see blurred or missed lines. So this is a part of a central cecal scotoma, and here you can see a part of arcade scotoma coming up in the border of the Amsler grid in a glaucoma patient. If you ask what's the most important use of Amsler grid, it is in the monitoring of AMD. So a patient can be given a chart to do the monitoring at home. It helps in looking for the progression or development of new scotoma or distortion. So when you have a patient with dry AMD, he can be asked periodically to monitor his vision with each eye, giving an Amsler grid at home. So if a patient develops a new scotoma or a new distortion, that means it may be a conversion of dry to wet AMD. Also, in a patient with a silent or quiescent CNVM, development of a new scotoma or distortion may indicate a new activity or a continuing activity in a CNVM. So it's also useful in other conditions like diabetic macular edema, CSR, as I earlier mentioned, and ERM with pucker, where we can decide on surgery. A patient may be having a 6/6 vision, but a documented metamorphopsia may be an indication for ERMP. And in advanced POAG, where the vision loss has encroached central fixation, you may see changes in the Amsler grid. And it's also useful in finding out if a patient has macular sparing in patients with hemianopias. So Amsler grid, it is a simple clinical perimetric method. It's cheap and freely available to assess central visual field. It is easy to detect and monitor progress of sight-threatening macular conditions with this simple test, and it's a valuable tool for self-assessment. Thank you.
Papa, you can conclude.
Thank you, Dr. Manjit, for that nice and crisp talk. I would like to thank the Ksos and Rajivan sir for giving us this opportunity. Thank you all other speakers also. Thank you very
Thank you,
much.
madam. It was a fantastic session. It is very educative. And what I'm going to do is to divide this video into small sessions in various topics so that it will be very useful for the postgraduate to search and refer. Because the entire program is about 5 hours. To get a 20 minutes or 30 minutes program, it's very difficult. So I'm going to divide it and upload it with index so that you can search and get it properly. So I thank all the speakers in this session, Papa Madam, Gopal, and Manjit, and Manoj, all the 4. Excellent talk it was. And we have Sashikumar sir there waiting to say something. A few words from him.
So, we have started this PG program last year and it has gone on well this year also. It has been very well. Good evening, Vijayaraman sir. We have got very eminent teachers like Vijayaraman sir this time. And I think KSOS will continue with this program because this is a very, very important session to reorient our freshers to this field of ophthalmology. Right now, ophthalmology has become so high tech that people, when they come to the first year program, they'll get bewildered by all those high tech gadgets. So through this program, we were able to give them at least an orientation of what all our high tech investigative modalities are there. It's a very good initiative, and I think KSOS will continue it in future also, and will include more and more very good illustrious teachers from our own side and from outside for this program in future. And thank you, Rajiv, for organizing such a wonderful program. You have made this negative situation of COVID into a positive reality, and I think the 2 people who have turned COVID into a positive situation are sitting here. One is Dr. Rajiv and the other is Dr. Gopal. Hats off to them. Thank you.
Sir, I want to say that Vijay Raghavan sir is not outside faculty. He's our own faculty.
Number is 312 or something.
Yeah.
232.
232, I'm sorry. Even very senior KSOS member. Okay, sir. Anything to say, sir? Vijayram, sir?
Oh, thank you very much. Thank you very much.
Mahesh?
Nothing. Congrats, Rajiv. He is sitting there from morning to evening last 2 Sundays. And
okay, no problem. I was really enjoying the complete program. The only thing is we need to index it, and so that it will be easier for people to watch the particular topic they are interested. So for searching it.
Yeah, I think when the physical meetings start also, these sort of problems, it is better to make it online so that they can access. More people will attend, like this, the freshers program, all these things.
No, even during physical meeting, we can have a telecast to
something
YouTube
like
or something like that. So hereafter, I think that will come.
Yeah.
Now COC can do it because they've crossed 1,000 subscribers. They can do it live with their mobile itself. Okay, with this, we are winding up this program. Thank you so much. Thank you all for cooperating. It was a wonderful session. We could manage, and our NCED inaugural function will be on Wednesday at 4 o'clock. All are invited for the function. It will be live on YouTube and Facebook. Thank you so much.